most everybody in this room. So, but we're really we're really delighted to talk about hospice, and what we're going to do today. John Seelert, who is CEO of Boca Grande Health Clinic, he's going to talk for several minutes and just kind of let y'all know how all of this has evolved. And then Carol Conway from Hope Hospice, she's going to probably talk about 20 to 30 minutes, and then we're going to leave lots of time for questions and answers. So again, thank y'all for coming. I'm going to turn it over to John Seelert.
Thank you, Dr. Steffan, and thank you too for coming out today. We really appreciate it. I wanted to take a few minutes and talk to you just a little bit about the background of how we kind of got here today, because I think it's important to have this as kind of a foundation for our discussion. And there's some exciting things that are going on that I think down the road will benefit by even a whole lot more. So, what was it, about a year ago? Several interested citizens in the community, Rosemary Bowler, Pat Chapman, and others, approached the clinic about concerns that they were having about inpatient hospice care. Since we're Lee County, our patients have to go to the nearest Lee County facility, and that would be in Cape Coral. And that was putting some undue burdens on family and friends who wanted to go and be with someone at that stage. And so we thought it was valuable and worthwhile enough that we reach out to Hope Hospice, this is their region, Lee County, for hospice. And we'll hear a lot more about their organization and how they operate. But reach out to them to talk about our concerns. And so we contacted Samira Beckwith. She's the CEO at Hope Healthcare Services, which Hope Hospice is a part of. And we were received very warmly, very openly, and it was really encouraging. Rosemary and I went over, had a meeting with Samira and some of her senior staff, and that's where we met Carol Conway, who's going to talk to you today. We got an immediate response concerning the concerns for Boca Grande patients and residents. And what our thinking is there's a hospice house that Tidewell has in Lee County. Why can't we go to that nearest hospice house? Well, they basically said, you can. We can make it happen through our ability and our relationships with Tidewell to do those kind of things. And so as a result, we got Michael Tobiasen, who's here right now. Mike, raise your hand. Yeah. Michael's our clinical liaison with Hope Hospice now. And so anytime we have a need for a patient, regardless of whether it's for home care or whether it's for Tidewell, trying to get into Tidewell or anything, we can go straight to Michael and he can clear the path for us. So he's our liaison, our ombudsman, our be-all, end-all for clinical affairs. And Carol is become our business-to-business liaison partner. And I want to talk a little bit about where things may be going in this relationship. And we're calling it a collaboration or a collaborative. And so what we've discussed so far, some of the goals for this collaborative, are to better inform our community about end-of-life options, i.e. hospice and other things. Together, I think we can do a lot in this regard. To find ways to provide specialized and immediate support for patients that are nearing the end of life. And then find ways to help people stay in their home. I think that's what ultimately, if we can do, that's the best outcome for people. So there are challenges and opportunities in trying to do something like this. We have the remote geography. We're here, Lee County, disconnected from the rest of Lee County. And so the geography to come from Lee County over here to provide resources, you've got at least an hour or more to get the resources from Hope to us. And so we think there's ways to collaborate. with the resources of the clinic and staff, with Hope Hospice, with technology, that we can do more. And so we feel that we have a community, as evidenced by you, that is receptive to these goals and innovation. We have an educated community. And so I think that we can come up with ways to better serve you in new and different ways. Maybe, who knows, we might become a model for others. But both organizations are well established, have high quality reputations, and so we think it's something to build on together. So here are the potential directions that we can take, and we can work to provide more comfort care earlier to people. I think Carol can talk more about these kind of things. Technology, telehealth, will allow us to monitor people in the homes and identify their needs sooner. We can also work to deploy continuous resources in the home if necessary. And then Hope has the expertise in this area, and they're willing to cross-train our staff and others to be able to respond to these needs. The other thing is the clinic has an externship program in which we help train medical assistants for Southwest Florida College. They rotate through us and get their externship. We think that we might be able to draw on that because this would be a good opportunity for them in their externship as well as another resource for us. So, and then the other thing is that we have a community that gets behind the needs of the community and help support these things. So we would want to expand this collaborative to include the community and how we can draw on the resources of the community to further this program. So with that as the background, I'm going to turn this over to Carol Conway, Director of Mission Support for Hope Healthcare Services, okay? Good, thank you.
I think John should get around the applause. Can you hear me? Ooh, I've got all the power now, don't I? With the sound here. Thank you for being here today. I know you have choices in terms of where you spend your time and how you spend your days. I want to especially thank Rosemary because she has been such an inspiration in terms of talking about what the citizens of Boca Grande need and want, really reaching out to Hope Healthcare Services and initiating this. And Pat has been lovely as well, and John, of course, is fantastic in terms of bringing us up to speed. I want to bring you a little bit of background about myself and give you some perspective as to why I'm here. I don't even come from a healthcare background. Don't let that scare you because I'm not going to be providing any aid as it relates to clinical. But I owned and operated my own successful business for 19 years in the Lee and Collier County areas. And I found myself facing a mother with Parkinson's disease at 76 years old, osteoarthritis, and in declining health. I've got an 86-year-old father who is in a skilled nursing facility, and he is completely dependent on others for his needs. I am well educated. I've had a pretty successful life. I've got good resources in the way of friends and family, and I found myself paralyzed in trying to navigate through the clinical, medical, insurance options and feeling incredibly humbled and scared about what to do next and what's the right thing. And I've got a sister who I would say is comparable to me, and she feels the same way. I sold my business a few months ago. I joined Hope Healthcare. I was thrilled to be offered the position, and my job and my interest is making it easier for other people to navigate through the myriad of issues, resources, problems as they reach end of life. I'm just not interested in your last few days or your last few weeks. I'm interested in what life is like from the time you're about 55 years old to the time that you pass away, and helping people get through that difficult time. I would like to say that we've got some needs here. I would like to say it is depressing, but there are so many good things that I know are available in the way of resources and help. It's a matter of navigating through it and doing it successfully so that your loved ones and yourselves can have true quality and true meaning to each and every day that you have, whether it's another 16 years or it's another 6 days. What I'd like to share with you is I find this to be a passion and a calling now, and I choose it. And I got to choose what I wanted to do when I sold my business, and I chose Hope Healthcare Services. Very similar to working with the Boca Grande Clinic and the Boca Grande citizens. You are like-minded. You are about treating the person, the family, and the holistic aspects, not the symptom. You're about total quality of life, not specialized and specific, but how do we maximize everything we do every single day to make it rich and rewarding? And so I think the collaboration between our two organizations makes so much sense because we've already got a mission, we've got values, and we've got common goals that are extremely similar. With that in mind, I'm going to tell you a little bit about Hope Healthcare, not to put you to sleep, and I'm not going to go through every circle that's on the slide. But what I want you to see is that we've got 30 years experience as an organization in healthcare issues, and we are so much more than hospice. And that's important to know because it helps build that bridge of services and resources and programs from 55 through end of life. And it talks about dealing with people. The programs and services that we offer are all similar to hospice in the respect that they deal with spiritual, clinical, emotional, physical, financial needs of the patients and their families. Each plan of care is designed uniquely to what that family and that individual needs. There are no two plans of care that are identical in any of our programs, and I think that's important to point out. The first thing I'd like to review with you is a program, and it's called our PACE program, and that stands for Program for All-Inclusive Care for the Elderly. Once again, that's Program for All-Inclusive Care of the Elderly. PACE deals with people that are qualified for skilled nursing, but they would prefer to stay and live in their homes as long as possible, and as long as we deem that they have a safe environment, that is our goal and objective as well. PACE is for people that are 55 years or older, and most of our PACE patients are Medicaid patients, although we do have dual eligible Medicare and Medicaid, and we do take private pay. I don't know that the PACE centers are appropriate for the Boca Grande citizens because you have your clinic, you have already a system to support your day-to-day needs. But what I would like to say is it lets you know that we've got a level of experience in working with people, whether it's finding needs for their podiatry, for their dental, for their cardiac, their socialization needs, dementia, and it is an interdisciplinary team. No one specialization ever meets without the others. Every patient on a routine basis is looked at holistically with multiple disciplines to make sure that everything fits together beautifully, cleanly. In addition to doing the right thing for the patients and doing the right things for the families, what does it also do? It helps save costs because people aren't needlessly getting procedures and processes that aren't thought through in their entirety. In fact, I'll show you a slide a little bit later in the presentation that talks about some of the needless spending that goes on if you do not have a coordinated plan of care. So the PACE model, which we've been doing for the last 8 years, we've got about 250 participants in PACE, and we plan to double that over the course of the next 18 months, is a funded through the government. It's a Medicare, Medicaid funded program. We have to be certified to do it, and you have to have all disciplines involved in PACE. So you have nurses, dietitians, physical therapists, occupational therapists, people that can deal with psychosocial needs of patients, and all the specializations that we contract for. I share this with you because I think it's important you know that we are so much more than hospice, and we've got experience in working with people much earlier than what most people assume. And this is not typical of every hospice. You will find hospices all over the country have different levels of program and services. Some are hospice only. Others have a myriad of things like we do. I'm just pointing out specifically in this particular instance what we have in the way of background. The next program I'd like to tell you a little bit about is Comfort Care. And Comfort Care, in its most basic, is relieving symptoms and making patients more comfortable. Most people in Comfort Care are seeking aggressive treatments. So you've gotten a diagnosis, you've got a serious illness, you want to continue to prolong your life for as long as possible. We have many people in our Comfort Care program, and what they are receiving is a call perhaps once a month from a social worker or from a nurse, touching base with them. How's it going? If you had any changes in your life, oh, I'm so glad you called. My husband the other day had an incident. It's put a lot more stress on me, blah, 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 blah. Just by keeping in touch with people at the most basic level where you can start seeing where they are and what levels they need in the way of support. As their needs grow, we have home health and we've got homemakers that we can contract for additional services. You're still living a pretty vibrant life. You're still getting aggressive therapies, but you like to have a little bit extra in order to assist you. Consider this to kind of be like private duty services in your home. But what happens is we're starting to understand your medical needs earlier on, so when you are more appropriate for other services, we are already involved with your plan of care. We already know who you are. We already have a sense. So Comfort Care is another program that we've been offering over the course of the last 5 years. Part of good caretaking is helping people's hearts heal. And patients that are at end of life, they need to bring things to closure. And having qualified chaplains, social workers that can deal with patients and helping them to come to closure on unresolved issues and wishes is very important. But for so long and for so many years, we've neglected the needs of the family, and we haven't gotten involved in the bereavement process earlier enough with families. And a lot of what we can do when we understand a patient's needs, whether it's PACE to Comfort Care to hospice, but somewhere along that continuum of care, what you have the ability to do is start working with anticipatory grief and start helping people through that process and funnel so it's not so burdensome and it's not so horrific. And the more the patient knows that the family is prepared and ready to deal with these issues, the better quality for everybody involved in this circle of care. So our programs and our resources in bereavement are immense, and they apply for all of our programs. We do have kids care programs. We only have about 120 kids in our care within the hospice area, but hospice isn't limited. One of the myths of hospice is you've got to be really old to qualify. You can get hospice care if you've got a terminal illness and you're under 65, and we do have some programs that are specific to pediatric needs. I'd like to talk a little bit about our expertise in the Parkinson's area. That's near and dear to my heart because of my mother's Parkinson's, but we have 1,000 people that are registered as Parkinson's participants. They're not actually patients. They're not receiving clinical services from us. What they're receiving is educational, programmatic, exercise, some therapeutic things to keep them moving and grooving a little bit longer, and we refer them to Parkinson's experts and neurological specialists as they have needs. We do a great deal with the Parkinson's community, and many of our Parkinson's community are involved in our Comfort Care. And we find that having expertise in that particular area has been very beneficial for the Parkinson's participants, their caregivers, as well as for Hope Healthcare Services. We have a Valor program that is very robust, and this is very specific focus for those veterans and what their emotional needs are and how to treat them clinically and to better understand some of their triggers. My dad is a World War II veteran. He served in the Navy, and where he is at in his skilled nursing facility, he's been through the Valor program, and he's not a hospice patient. He's just been through the Valor program, and my dad probably is going to outlive me. He's 86 years old, and I'm telling you, he gets really good care, and he is doing great. But he's got dementia. He is bound in a wheelchair. He needs help in terms of transferring and moving. But when they came and honored my dad in recognizing his service to the military, they gave him a pin. They gave him a plaque for his wall. There was saluting going on. These can be done in groups. They can be done at bedside. They can be done in different event settings, 4th of July, Memorial Day, etc. The veterans and their families really respond positively. And understanding that there are certain clinical and psychosocial needs from a veteran in preparing staff to deal with that and preparing families to deal with that is interesting. Before my dad ended up breaking a hip and in skilled nursing and going through what looked like at the time a rapid decline, for about 6 months prior to that, he wanted to talk to me about his military service continually. My dad spent 40 years not talking to me about the military experience. But all of a sudden, he couldn't tell me enough. I didn't realize at the time that my dad was starting to go through some of that decline. And now I'm better prepared to share with other people how important that piece of history is. And said, well, you World War II guys, and gals, aren't going to be around a whole lot longer, but guess what we've got? We've got Vietnam, we've got Iran, Iraq, Afghanistan. There's not an end in sight to the needs of our veterans, and it's nice that we can serve them specifically and uniquely. And I'd also like to say we have a lot of volunteers. Hope Healthcare Services has 1,000 employees. We're in 5 counties with different services, and we have 1,200 volunteers. We actually have more volunteers that work with us than we do employees. One of the conditions of reimbursement for our services is that a certain percentage of dollars are there based on volunteer participation. And I think it's a minimum of 5% of patient care has to be delivered through volunteers. And we're not talking about changing IVs. We're talking about, reading, assisting, holding hands, pet therapy, a variety of things that are of interest. We actually do about 9%, and our volunteers are very engaged, and most of our volunteers are people like you who've experienced hospice. We've been of benefit. You like to give back, and so I'm not recruiting for volunteers today, but I will. I'm happy to, because there's nothing better than being able to serve within your own community, and we really count dramatically. I mean, our volunteers make a dramatic difference to us. Now, I want to talk a few minutes about the truth of a hospice, but before I talk about dispelling some myths and the truths about hospice, I want to give you some background. Hospice was started in the Middle Ages, basically, and I'm not going to go way back then. But where it's the most recognizable is in 1905. There were 5 sisters, Sisters of Charity, and they were from Ireland, but they actually set up hospice in London, and they had 2 benefactors that gave them money to serve the needs of the terminally ill. It then migrated to a social worker, a doctor, and a nurse many years later, 30, 40 years later, in a different hospice in London, said, I think death is more about the social needs and about the emotional needs and about the bereavement needs in addition to the clinical needs. And this is when the push for more of a holistic approach toward hospice really came into play by using different therapies and appealing to different people in different ways to make their end of life unique and special and appropriate. And so this particular woman, she was a nurse, and she's the one that really perpetuated this. Her name was Cicely Saunders. She was speaking in the United States at a conference, and Yale New Haven, Connecticut medical group really latched onto this concept of hospice in a holistic way, in a complete and thorough way, and that's really where it got launched in 1974 in the United States. Florida, as you might imagine, was a candidate for hospice based on our warm weather and beautiful conditions, and we were, in I think the late 70s, we became licensed as in the first state to be performing hospice. Around that same time, Hope Volunteers actually started Hope Hospice, and it was just a ragtag group of people that were trying to put together an organization, and we became licensed in 1984 as a full-service hospice and governed by all that implies. Our CEO, Samara Beckwith, which John alluded to earlier, she's quite a visionary. She's been involved in legislation. She was part of the 1984 legislation as it started coming into and really getting some steam, and she's been a part of all the significant changes that have happened within the hospice environment. She has been serving in hospice for 30 years, and she's been with Hope Healthcare for 20. So we've got some longevity there, and she's young. She's 60 years old, and she's got more energy than all of us combined. She's really quite remarkable. So that's a little background, and hospice is a combination of hospitality and hospital. That's truly, it was meant to be respite, it's meant to be care, it's meant to be service, it's meant to be clinical. That's how the term came about. Now, we all know that healthcare is a big black hole when it comes to finances. And you also know that the government Affordable Health Care Act, legislation that is current and pending, is all trying to make it better for patients, better for families, but to keep us fiscally aligned. If you look at this particular slide in 2008, and it's only escalated from there, but the data that we have in some of these cases just isn't that current. $50 billion was spent on patients in their last 2 months, terminally ill patients in their last 2 months of life. $50 billion, and 20 to 30% of those were deemed medically unnecessary or not substantial. Just think about it. The budgets were greater than our Department of Education and Homeland Security. That gives you an idea of how much is going on. Is this because hospitals are trying to take advantage of you? No. It's because their focus is different. They're looking at saving and solving a specialty, an area, as compared to a holistic approach in terms of what is right, appropriate, or necessary for a patient. So this cost of doing business is extremely, extremely high. And in addition to being high, we could do a lot better. 9 out of 10 people say they want to die in their home. I don't know anybody that thinks that it's a good place to be at your end of life in a hospital. So that being said, I'd like to spend a couple of minutes just dispelling some truth, some myths about hospice. And the first myth is that we have doctors that say, I'm fighting to the end. I'm going to give aggressive treatment and aggressive therapies. I'll never say die. And I appreciate the enthusiasm, the commitment, the gusto, and the resolve that's there. But it's not always in the best interest of the family or the patient. And a balanced approach, at least in terms of educating patients in terms of what their rights are and what they do or don't get with hospice, is part of the job that I'm charged with, as far as making sure that we're giving good education in the community to our physicians that refer to us, because so frequently we get patients way too late, a couple of days versus a couple of months. And the difference that hospice can make if we're in somebody's life a couple of weeks even is dramatic. Can you imagine if you're following a family for 6 months, how you can impact and truly create an environment that is quality and is caring and that eliminates pain and suffering at multiple levels. So mostly what happens is people don't go to hospice. People do go to hospice and they die eventually. That's a fact. That being said, if you look at this, I think you will be surprised. A study was done, I think, in 2007 of 4,500 people, and they were terminally ill with the things that we see for our seniors.